welcome all the members of this community for this presentation. So, carcinoma larynx is a vast topic because there has been a trend in more of surgical procedures for early carcinomas. There's been a trend with chemo RT for moderately advanced carcinomas, but still for T4 and advanced lesions, surgery is still the mainstay. So, there's been a dramatic difference in how carcinoma larynx is perceived or has been perceived in the last 2 decades. And there are several important aspects to consider. So let's begin. So all of you know that the larynx has three subsites. There is the supraglottis, the glottis, and the subglottis. Now each of them have a varied presentation, and each of their outcomes are quite different. In the mix, we also have transglottic tumors, that is, any tumor that transgresses the ventricle in the vertical axis. And then we have marginal zone tumors, which are tumors of the aryepiglottic fold. And these can behave either as a hypopharyngeal tumor or as a supraglottic tumor. Now, the difference in the anatomical differences, the supraglottis is the part of the larynx that's above the vocal cord. The glottis is the part of the larynx that is at the level of the vocal cord, and the subglottis is from the inferior surface of the vocal cord up to the first tracheal ring. So, like I mentioned, each of them have different presentations, which we will see a bit later. Now, the etiology, as you all know, is smoking and alcohol consumption. Smoking is particularly important etiological factor for carcinoma of the glottis, and there's a way of documenting the smoking history. You have to calculate it in pack years. So, smoking 20 cigarettes a day for a year constitutes a pack year. And there's always been studies on the additive effects of alcohol consumption on smoking. So if someone consumes alcohol, they are at a higher risk for developing supraglottic tumors or tumors of the hypopharynx. So these are the only known two etiologies that we know. Now, HPV has been described in supraglottic carcinomas, but there have been no definitive epidemiological study so far. So maybe in the future, a viral etiology also would play a role. Now, how do you evaluate a patient who comes to you with the symptoms of hoarseness, breathing difficulty, change in voice, or swallowing difficulty? Obviously, the first thing that you do is an office laryngoscopy. The office laryngoscopy can either be a rigid laryngoscopy or can be a flexible fiber optic endoscopy. The advantage of the fiber optic endoscopy is that you are able to evaluate the entire upper digestive tract, starting from the nasopharynx, soft palate, posterior pharyngeal wall. These are some of the sites that are missed with the rigid endoscopy. But the evaluation of the larynx shouldn't stop with the laryngoscopy in the office. Obviously, you need to do a direct laryngoscopy or examination or anesthesia in the theater. The reason for that is that there are several hidden areas of the larynx, especially if you look at the ventricle, if you look at the immediate subglottis, if you look at the anterior commissure, if you look at the petiole of the epiglottis. These are some of the sites that might be missed on a clinical examination. So in your exam, always prior to the management of these tumors, you do have to mention office laryngoscopy and examination and anesthesia in the theater. Now, there's a lot of things that you have to know about the imaging of laryngeal cancers, and that is important in today's context. Gone are the days where simple laryngoscopic examination and a simple CT scan would have sufficed in determining the treatment of these patients, but now I will spend some time on the advanced imaging of laryngeal cancers. So, right now, a combination of CT and MRI are useful, and these are because there are potential sites or potential spaces in the laryngeal framework that are not, you cannot see them either with an EUA or with traditional office endoscopy. Uh, since the etiology is smoking, you always have to evaluate for a second primary in the lung or a synchronous tumor in the lung. And this can be done with a plain CT chest. You can see for nodules or you can see for metastasis. And finally, probably the most important thing is the functional status of the larynx. Imagine if you have a patient who has got an advanced laryngeal cancer who comes to you with a nasogastric tube as well as a tracheostomy tube. That is, both the breathing as well as swallowing is impaired. These patients are poor candidates for any organ preservation modality because your organ is already dysfunctional. So, a pre treatment evaluation of swallowing and the airway is very important before embarking on these patients. Now, we are in the era of organ preservation. Organ preservation means that you have to submit the patient to a treatment where the larynx is anatomically preserved to a certain extent, but the functions of speech, swallowing, and airway protection is still maintained. Now, I put up this slide early on for you to understand that there are some principles. A question in the exam, what is organ preservation in the larynx? There is surgical organ preservation as well as there is non-surgical organ preservation. Now, the four important aspects for surgical organ preservation are local control, accurate assessment of tumor, understanding that the cricoarytenoid unit is the basic functional unit of the larynx, and we have to adhere to standard resection technique. Now, local control is important because what will happen with organ preservation surgery is that the topography of the larynx will change, meaning your follow-up might be difficult because of loss of anatomical reference points. So you should not compromise on local control when following organ preservation surgery. The second is the accurate assessment of the tumor extent. This is specifically for places like pre-epiglottic space, the paraglottic space, sorry, or the laryngoventricular complex and the anterior commissure, because uh, these are important for us to three-dimensionally map the tumor and excise the tumor with margins. Now, when you're undertaking any functional organ preservation surgery of the larynx, you have to understand that the cricoarytenoid unit, it's not the joint alone, it is the cricoarytenoid unit, that is the muscles attached to the cricoarytenoid joint, the nerves that innervate the cricoarytenoid joint. These comprise of the cricoarytenoid unit, and preservation of at least one cricoarytenoid unit is essential to have some laryngeal function at the end of the surgery. And sometimes, when we resect tumors in an organ preservation manner, we have to excise slightly more than what is conventionally required. And should be able to, we should be prepared to do that, and we should adhere to the standard resection technique. Now, when it comes to imaging, you have to understand how to request the CT and MRI. This is especially the case when you're working in a small town and you need to specifically ask the radiologist in the scan center to acquire the images for the larynx and not for the general neck, because we need to assess the spaces, we need to assess the cartilage erosions, we need to assess the pathways of spread. The points of concern here are the laryngoventricular complex, the paraglottic space. Now, as I mentioned to you earlier, unless you map the tumor both endoscopically as well as through imaging, you cannot undertake an organ preservation surgery in these patients. So, it is highly relevant for surgical planning or for other treatment planning. So for CT acquisition, the patient has to lie supine, breathing quietly. You do an axial scan, and the acquisition plane is parallel to the hyoid bone so that you can obtain scans that are parallel to the vocal cord. And you have to have a section thickness of 0.75 millimeters to obtain high sagittal quality sagittal and coronal formatted images. Because what will happen is they will take the axial image and then the software will reformat it to the coronal and the sagittal. So unless you have a very thin axial image, you will not be able to get a good coronal and a good sagittal image. So you have to specifically ask the radiologist to give you a 0.75 millimeter axial cuts. The field of view and the matrix is not of a concern. That is done by the radiographer. And we need to see the images both in the soft tissue as well as the bone windows. Now, if you can do some additional maneuvers, you can look at the ventricle, anterior commissure, and the aryepiglottic fold. So what we do is we ask the patient to do E phonation, and that will give a better picture of the ventricle, the anterior commissure, and the aryepiglottic fold. And you can do a modified Valsalva to assess the piriform sinus and the postcricoid region. So you can ask for these maneuvers from the radiologist. The MRI, you have multiplanar acquisitions nowadays. So non-contrast T1, T2, T2 fat suppressed, and post-contrast T1 fat suppressed. It is important to take both the T1 and T2 sections at the same level, and the section thickness is 3 millimeter, and the interslice gap is about 1 millimeter, and the patient has to be absolutely still for cases where MR is being taken. Now, the structure of the larynx, as you all know, starts with the epiglottis. Then you have the thyroid cartilage, the cricoid cartilage, and the paired arytenoids. We have the laryngoventricular complex. We have the paraglottic space. We have the pre-epiglottic space, and we have the anterior commissure. Now, one important thing that they will ask you in the exam is that how do you differentiate from tumor, uh, destruction, sclerosis, and tumors which are breaching ossified cartilage? So, the imaging appearance of the cartilage depends on whether they are ossified or not. So, the vocal process of the arytenoid and the epiglottis do not ossify, and non-ossified cartilages have soft tissue attenuation on CT and low to intermediate signal on T1 weighted and T2 weighted images. On CT, the ossified cartilages are hyper-attenuating, and on MRI, ossified cartilages are low signal, and their fat medullary cavity is of high signal on T1 and T2 images. So you should know what are the characteristics of the ossified cartilages, the non-ossified cartilages, and how they would appear on the CT and MR. Now, one of the important things that we need to look out for is the cartilage invasion, because cartilage invasion automatically makes a tumor T4. So MR has a high sensitivity but a lower specificity as compared to the CT for detection of cartilage invasion. But the negative predictive value of MRI to exclude cartilage invasion is very high. That is about 94 to 96%. So MRI can rule out cartilage invasion. So if you are in doubt, do an MR, because that will give you whether the subtle erosions are present or there is a transcartilaginous spread of tumor. So you have to remember that if you see an ossified cartilage, that area is most susceptible to tumor invasion. Problem is, when you try to demonstrate invasion in non-ossified cartilages, the CT is slightly problematic because it has similar CT density. So laryngeal cartilages which are non-ossified are best seen with MRI, but MRI can overestimate because of inflammation. So the CT signs of erosion and extralaryngeal tumor of the thyroid, cricoid, and arytenoid cartilage, together with the sclerosis of the cricoid and arytenoid cartilages, has a sensitivity of 64 to 72%, but the specificity is slightly higher. So the signs that you look for, which makes a tumor T4, that is either extralaryngeal spread or destruction of the cartilage, is erosion and extralaryngeal spread of the tumor through the cartilage, or the presence of sclerosis of the cricoid and arytenoid cartilages. Sclerosis is actually a very sensitive criterion, but sometimes if you have reactive inflammation, especially in the region of the thyroid cartilage, it can, have a false positive reaction, a false positive result there. So look for extralaryngeal spread, direct destruction of cartilage, and sclerosis of the arytenoid and cricoid cartilages. Now, the important thing is that when you do endoscopy, we look at the mucosal disease. But when you do imaging, you look at the submucosal disease and involvement of the spaces. So the key in the radiological assessment is the identification of the laryngoventricular complex and the paraglottic space. So, what is the laryngoventricular complex? So, on axial images, the superior margin is at the apex of the arytenoids, the false chords, the fat-filled paraglottic spaces deep to the false chords, and the inferior margin is a section through the true cords with the thyroidnoid muscle and the cricoarytenoid joint. So these are some pictures of normal CT imaging. Here you can see the beginning of the epiglottis, and then you can see here the paired vallecula on either side. And as you go lower down in the CT, you can see the pre-epiglottic space, and you can see the ariepiglottic folds also. As you come down, you can see the piriform sinuses, and you're entering and seeing the paraglottic spaces here. Here you can see the arytenoid cartilages, more clearer image of the paraglottic space, and this is the thyroid cartilage. And as you go down, you can see the level of the cricoarytenoid joints and the true vocal cord. And this is a section through the subglottis. So remember these findings here. Any effacement of these areas or spaces indicates that the patient has tumor extension there. Now, the importance is when you're looking at the sagittal, the coronal images, along with the axial images, we have to look at the paraglottic space. Now, the paraglottic space is located deep to of the true and false cords, and it lies between the lateral extent of the true and false cords and the thyroid cartilage. Now, the importance of the paraglottic space is that it has direct communication with the extralaryngeal soft tissues, and it's also an important pathway for extralaryngeal tumor spread. And it also is one of the relative contraindications if you're trying to do organ preservation surgery endoscopically. So the significance of paraglottic space, as I mentioned to you, is that it's one of the pathways of spread extralaryngally, but it can also be secondary to a glottic or supraglottic carcinoma. It does not have to be that a vocal cord lesion extends laterally to the paraglottic space, but it can be from the supraglottic carcinoma as well. So carcinoma of the mid or posterior glottis spreads into the paraglottic space and causes vocal cord fixation. It can also spread to the false cord superiorly and to the ariepiglottic fold. It can extend to the preepiglottic space and can also go submucosally to the piriform sinus via something called the thyroarytenoid gap. And it can go via the cricothyroid membrane to invade the soft tissues of the neck. So paraglottic space is a short note question. The anatomy of the paraglottic space is important. Pathways of spread from the paraglottic space is important. So the posterior paraglottis has a different spread than the anterior paraglottis. And so these are some important points that you have to remember when talking about the paraglottic space. Now, this is a thyroarytenoid gap through which a paraglottic space tumor can extend extralaryngally. Now, the next space is a pre-epiglottic space, which is rich in lymphatics, and it's in front of the epiglottis, as the name suggests. It's superiorly bound by the hyoepiglottic ligament, anteriorly by the thyrohyoid membrane, inferiorly by the thyroepiglottic ligament, and posteriorly by the epiglottis. And the pre-epiglottic space and paraglottic space communicate with each other. Now, there's a very important aspect of the paraglottic space because gross pre-epiglottic space and involvement precludes excision via transoral laser, and you have to rely on some open partial laryngectomies. So the axial section as well as the sagittal section gives you a good idea of the pre-epiglottic space. So, what are the signs of soft tissue involvement in carcinoma larynx? So, bony involvement, I told you, destruction of the larynx, cartilage, extralaryngeal extension, sclerosis of the cricoid and arytenoid. But the soft tissue aspects are asymmetric soft tissue thickness or prominence, abnormal contrast enhancement, bulky mass obliterating the normal fat spaces or fat planes, or a combination of these. So, these are some of the soft tissue aspects that you have to look at. So if you have a supraglottic tumor, you have to look at the base of tongue because that's where the tumor can extend superiorly. You look at the epiglottic petiole because that's how it can go inferiorly. Once it goes to the petiole, you have to look at the anterior commissure. Once it goes to the anterior commissure, you have to look at the subglottis. Because it's supraglottic, it can go to the AE fold, the piriform sinus, and the paraglottic space via the preepiglottic space. If you have an aryepiglottic fold tumor on imaging, you have to look at the preepiglottic space, you have to look at the extralaryngeal spread, and you have to look at the piriform sinus. If you have a false chord tumor, you look at the paraglottic space, extralaryngeal spread from the paraglottic space, involvement of the thyroarytenoid muscle, or the involvement of the arytenoid cartilage. If you have a glottic cancer, again anterior commissure involvement, posterior commissure involvement, thyroid cartilage destruction, arytenoid or cricoid cartilage sclerosis, or cricoid cartilage destruction, along with extralaryngeal spread. So these are the things that you look for in the glottic cancers. And subglottic cancers here, this is a subglottic cancer because this is the cricoid cartilage. And subglottic cancers, again, destruction of the cartilage, destruction of the cricoid cartilage, specifically extension into the extralaryngeal soft tissues, or extension to the trachea has to be looked at. Now, this is a criteria given by Becker, and this is what we follow in our department for patients who have been evaluated by MRI for the larynx. So, if you have, this is a new criteria. They had an old criteria, they have a new criteria. So, we have to look at the signal intensities from ossified hyaline cartilage and non-ossified hyaline cartilage. So, if you look at the new criteria, in a T1 image, both will be low. Either in the ossified or non-ossified, the T1 signal will be low. If you have a T2 image, both are similar, that is the hyaline cartilage and the non-ossified hyaline cartilage have similar tumor, similar to that of the tumor. If you have the T1 enhanced image with gadolinium, again you have similar enhancements to both, but this is for the cartilaginous invasion alone. But if you have to compare that with the inflammation, what happens is when you have the inflammation, it's not similar to that of the tumor in ossified and non-ossified. It's higher than that of the tumor. Likewise, the contrast enhancement, both for ossified and non-ossified cartilage, the inflammation will have a greater enhancement than that of the tumor. So this is the Becker's criteria which we use for MRI. And these are some of the pictures for Becker's criteria. So now some recent advances, we are using dual energy CTs and spectral CTs. We're using MRIs with surface coils with slice thickness less than 3 millimeters. And we're using diffusion weighted imaging, which works on the principles of movement of water. Now let's go into the treatment per se, and you have to understand that there are certain pitfalls in the current staging system. What we follow is the TNM staging system, and TNM is largely based on the subsites and the sites within the subsites that have been involved. But the problem is they don't take into account severe dysplasia and carcinoma in situ in the staging manual. The vocal cord mobility is a subjective assessment. Some people might call the vocal cord fixed, some people might call it restricted mobility, and that changes the T staging. Anterior commissure has a significant prognostic importance because the failure rates are higher on patients who have been treated with radiation for anterior commissure tumors, and they have a lower survival than patients who have mid-cord tumors. So, but the anterior commissure is not included in the staging system. And we don't have any biomarkers like P53 or key index that have been incorporated in the staging system. So, there are some pitfalls in the current staging system that we have. So this is the staging system for supraglottic carcinomas. T1 is when one site of the supraglottis is involved. T2 is when more than one site of the supraglottis is involved with normal cord mobility. T3 is limited to larynx or with vocal cord fixation and or invades postcricoid, preepiglottic space, paraglottic space, or minor cartilage erosion. And T4A is tumors that invade the thyroid cartilage or tissues behind the larynx, beyond the larynx. And T4B is when the prevertebral fascia, carotid artery, or mediastinal structures are involved. Subglottic cancers, again, T1 is limited to subglottis. T2 extends to the vocal cord with normal or impaired mobility. T3 is when it's fixed. T4 is when cartilage is involved or extralaryngeal tissues are involved. And T4B is the same as that for supraglottic carcinomas. But I'm not talking in detail about subglottic carcinomas today because they're very rare tumors and the treatment is generally the same when you compare it with the other tumors. Now, the glottic cancers are a big chunk of these tumors. So T1 is limited to vocal cord. That is T1A is one vocal cord, T1B is both vocal cords. T2 is when there is supraglottic or subglottic extension and or impaired vocal cord mobility. T3 is when it's limited to larynx with vocal cord fixation and or invades the paraglottic space or minor cartilage erosion. T4 is when the cartilage is eroded and it extends beyond the into the extralaryngeal soft tissue, and T4B is the same as the other subsites. Now, there's a lot of dilemma in how the early tumors have been managed. So, traditionally, T1 and T2 supraglottic and subglottic cancers have been managed by external beam radiotherapy with excellent results. So, if you look at radiation for T1, it exceeds 90% local control, whereas T2 lesions are slightly inferior, that is 70 to 80%. And radiotherapy gives better voice results than open partial laryngectomies. I'm not talking about transoral laser. And we have a lot of availability of trained radiation oncologists and facilities. So, still in our country, T1, T2, that is early tumors are treated by radiation. Now, what is the dilemma? So, changes in the last 2 decades, huge improvements in the instrumentation and techniques to visualize the larynx. Transoral options have evolved. And these are the questions that you have to ask yourself when you look at partial laryngectomies or transoral lasers compared to radiation for early tumors. Does surgery compromise outcome? Does surgery compromise voice? Does RT compromise outcomes? And do head to head comparisons exist? Unfortunately, for early tumors, there is no head to head comparison. We have a lot of meta analysis data and systematic review data that say that the outcomes between the two are comparable and organ preservation surgery and radiation have similar outcomes. So the unfortunate thing is that we surgeons must rely on the critical appraisal of non-randomized studies with different patient populations, cancer staging, and outcomes. So it's not a very clear answer unless we have, you know, randomized control trials comparing the different treatment modalities. No, I told you initially that these tumors behave differently. So early glottic cancers, they have no lymph node metastasis usually. There can be involvement of the paraglottic space that is obvious only on MR or CT imaging. The differences between T2 and T3 are subjective. T3 is fixity, T2 is impaired mobility, and higher forms of early glottic carcinomas, meaning carcinomas which have anterior commissural involvement are literally radio resistant and hence organ preservation might not be feasible. If you have looked at the early supraglottic tumors, they have higher chances of occult metastasis. There's involvement of the marginal zone and the piriform sinus. There's occult pre-epiglottic space involvement, and they're easily upstaged to stage 3 because of the nodal status. And subglottic cancers have higher chances of occult mets. They have poorer outcomes and there are no large series to decide which treatment is the best in these patients. Now, what is the problem in recommending radiation for all early T1, T2 laryngeal carcinomas? If radiotherapy is employed and if the patient has a failure, further surgical salvage is left to a total laryngectomy. And this is what is done in more than 70% of patients who fail. And anterior commissure is still a negative prognostic factor for radiation. But if you employ laser microsurgery, uh, these patients can be salvaged with further laser microsurgery, reserving radiation till the very end. But the problem here is as we go from a T1 to T2 tumor, and the tumor is being treated with a laser excision, T2 tumors have deeper resections, and hence they have an inferior voice compared to patients who had radiation. And the problem is radiation can take care of all the pre-malignant areas of the larynx as well as the field cancerization effects can be taken care of by radiation. Whereas if TLM is alone employed, we might miss potential areas of pre-malignant lesions, which can be missed in the surgical excision. Of course, there are various techniques now which have been used to highlight the like supravital staining and all the techniques based on supravital staining to identify the pre-malignant lesions. But still, the deeper the resection, the inferior the voice. So this is basically a brief outline of what treatment modality is to be followed for all stages. You have early stage cancer, that is T1. You can offer surgery to the patient or single modality radiation. T2, probably RT is slightly better than surgery because the voice outcomes are better and the surgical excision can be quite morbid. T3 is combined modality chemo radiation, and T4 you're left with total laryngectomy. Now, again, what are the organ preservation strategies? You can do the surgical and the non-surgical types. Surgical can be either open external types or endoscopic. So the open types are the vertical partial laryngectomy, the supraglottic laryngectomy, and the supracricoid laryngectomy. And the endoscopic is the transoral laser microsurgery. And the non-surgical treatments, as I mentioned, is concurrent chemoradiation or radiation alone. So let's go to supraglottic cancers, rich in lymphatics, bilateral drainage in the neck, higher chance of occult metastasis, bilateral cervical node metastasis, and you can have marginal zone tumors. And you can see in supraglottic tumors, the pre-epiglottic space, the suprahyoid epiglottis, infrahyoid epiglottis, all are at risk for having tumors. And the superior extent can be to the vallecula and to the base of tongue, and the inferior extent along the epiglottis can be to the anterior commissure, or posterior can be to the aryepiglottic fold into the piriform sinus, or it can involve the paraglottic space from the preepiglottic space. So this is just a picture of a supraglottic carcinoma. I'm sure many of you have seen many of these pictures. Now, if you have a T1, T2 supraglottic carcinoma, in the current day and age, if you have a young age patient, good lung reserve, and he's able to tolerate aspiration, slight aspiration, and if the tumor is limited tumor, not involving the infrahyoid epiglottis, this is very important. So in these patients, if the infrared epiglottis is involved, you can't do a transoral laser microsurgery. Otherwise, if the tumor is limited to the suprahyoid epiglottis, transoral laser microsurgery, supraglottectomy can be considered. You have to evaluate the patient and consider a bilateral neck dissection also. And the rationale is we have systematic review data. If none of these are possible, these patients can receive radical RT. But if the tumor involves erythenoids and it involves infrahyoid epiglottis and the patient has multiple nodes, I would still think that radical radiation or chemoradiation is slightly better. And you have to do an open partial laryngectomy. You can't do a transoral laser microsurgery for these patients. You have to consider an open partial laryngectomy. So, no pre epiglottic space involvement, limited suprahyoid epiglottis, you can do a transoral laser. Everything else, you can consider the patient for a supraglottectomy. Now, a supraglottic laryngectomy, this is the extent of tumor that is removed. Usually, it's the upper portion of the thyroid cartilage, the entire epiglottis, the hyoid bone is removed if it's involved, otherwise, it can be preserved. And then you take the upper part of the thyroid cartilage again. So, you're removing the entire preepiglottic space in these patients. And these patients tend to have decent voice outcomes, but this is probably the only procedure that can be recommended for massive epiglottis or pre-epiglottic space involvement. But if there's involvement of the cricoid or thyroid cartilage, if there's fixity of the vocal cord, if it is within 1 centimeter of the circumvallate papillae, or if there's involvement of the anterior and posterior commissures, you cannot do a supraglottic laryngectomy. Now let's look at the NCCN guidelines for supraglottic cancers. If you have T1, T2, N0 patients, you can do an endoscopic resection, as I mentioned to you, depending on the involvement of the epiglottis and the pre-epiglottic space, or you can consider an open partial supraglottic laryngectomy with neck dissection, or you can consider the patient for definitive radiation. If either of the surgical modalities show adverse pathological features or node positivity, then you have to consider the patient for adjuvant treatment. Now, if you have a patient who's got a T3 supraglottic carcinoma. We saw T1 and T2. Now at T3 supraglottic carcinoma, the treatment is concurrent chemoradiation. And this data we have from the RTOG studies that concurrent chemoradiation does preserve the larynx and does not adversely affect the overall survival. If the patient is not a candidate for concurrent chemoradiation, meaning if he's got impaired renal function, poor performance status, or the patient cannot tolerate chemotherapy for other reasons, then radiation alone can be done. Now, where does laryngectomy fit into a T3 tumor? Because all T3 tumors are amenable for organ preservation. If the patient has a dysfunctional larynx or the patient is old, cannot tolerate even plain radiation, then you consider the patient for a. Otherwise, we try to give concurrent chemoradiation if the patient's performance status is good and if the larynx is a functional larynx. Now, if you have a T1, T2 node positive, or you have a T3 node positive, still the treatment is concurrent chemoradiation. These are stage 3 tumors, and still you can do concurrent radiation. Some centers, especially centers in Germany and Italy, do a partial supraglottic laryngectomy with neck dissection. But the problem is, most of these partial laryngectomies and neck dissections will have adverse features, and then you have to add radiation or chemotherapy to the patient anyway. So instead of making it a single modality treatment, they make it a multi-modality treatment. So this is not generally recommended, but a concurrent systemic chemotherapy with radiation is what is recommended for a T3 or a stage 3 tumor. This is again the same issue. If you have a T3 tumor with an advanced nodal disease, again, concurrent chemoradiation is sufficient. And if the patient is a poor candidate for radiation or chemotherapy, you can try for laryngectomy with neck dissection. What happens if you have a T4 patient? That is a patient who has got cartilage involvement. The only treatment that we can offer these patients is a laryngectomy. And you decide on the side laterality of the neck dissection based on imaging and based on the laterality of the tumor. Once you do a laryngectomy, if the patient has positive margins or if the node shows extranodal extension, then you push the patient for systemic chemoradiation. And if they have other risk factors, you can consider radiation alone. Now, for patients who are not candidates for, or the patient declines total laryngectomy, then the options are quite few because concurrent chemoradiation gives very poor results in patients who have cartilage invasion. Now, glottic carcinomas have relatively poorer lymphatics. There are subjective differences, as I mentioned, in assessing vocal cord mobility. Anterior commission involvement is a poor prognostic factor. It's got close proximity to the paraglottic space, and cartilage erosion is seen in advanced cases. Now, if you're looking at a traditional approach to a T1, T2 glottic carcinoma, that is prior to the development of transoral laser microsurgery and prior to the development of radiation techniques, people used to do vertical partial laryngectomies. So you have a hemilaryngectomy, a frontal hemilaryngectomy, frontolateral hemilaryngectomy, and extended hemilaryngectomy. Now, the problem with these open external vertical partial laryngectomies is that you have to reconstruct the thyroid cartilage, and patients have some degree of aspiration and the voice quality is not very great. So that is why these have fallen into disuse, and we mostly focus on transoral laser microsurgery. Now, basically, what you're attempting to do in a T1, T2 glottic carcinoma is to do a cordectomy. Now, the cordectomy can be achieved in a vertical partial laryngectomy, or it can be achieved transorally using a carbon dioxide laser. It was popularized by Steiner and Ambrosch, and they were from Germany, and from the recent publications from Piazza and all from Italy. So there is a classification for this cordectomy, and this is based on the uh, you know the depth of the tumor that is there in the vocal cord. So if you have if you call a type 1 if you want to call a type 1 cordectomy, it is actually subepithelial cordectomy. Type 2 is a subligamental cordectomy. Type 3 is a transmuscular cordectomy. Type 4 is a total cordectomy, and type 5 is external cordectomies. Extended cordectomy, sorry. So as you go from type 1 to type 5, patients are going to have worse voice outcomes. So type 1 and type 2 are good, but as you become muscular and total, the voice outcomes are slightly poorer because there's a large glottic gap and the patients struggle to phonate. Now, what is the importance of these cardectomy, instead of radiation therapy? The radiation therapy for T1 glottis is quite, limited. It's not as long. People, hypofractionated RT, people have a shorter treatment duration, small field radiation. The voice results are excellent. But why do we still believe in the transoral laser microsurgery? Again, when you look at the indications for transoral laser microsurgery, is that young male, no habits, some degree of pre-treatment voice change, so that it is sort of compensated by the post-operative voice change, mid-cord lesion, limited mucosal or submucosal disease. Then we can do a type 1 or type 2 cordectomy. Now, the rationale is, even if you fail a type 1, type 2 cordectomy, we can still attempt another cordectomy in these patients, or we can give these patients external beam radiation. So we don't have to do a salvage total laryngectomy. So, in overall effect is that these patients have better laryngeal preservation rates. But if we have a patient who's got a T1 glottis with anterior commissure, then we have to do a type 6 cordectomy, where the anterior commissure also is removed. Technically speaking, it is quite difficult to do because visualization of the anterior commissure is quite difficult, and the voice outcomes are poorer with the transoral laser microsurgery. But data shows that surgery is better than RT for patients who have anterior commissure involvement in the glottic carcinomas. So, what do you do? This is the NCCN for glottic carcinomas. Carcinoma in situ endoscopic resection is preferred. RT not so much because you're basically using a bomb to level a small insect. So it is quite difficult to subject these patients to radiation. So CIS endoscopic resection is preferred. T1, T2, N0, you can give radiation, as I mentioned to you, hypofractionated, shorter duration, total duration, and smaller treatment fields. Or you can do a partial laryngectomy, either preferably the endoscopic partial laryngectomy, and in certain cases, maybe an open partial laryngectomy. If you have a T3 tumor, as I mentioned to you, all T3s now are organ preservation. Then we give concurrent chemoradiation to the patient. And if the patient is not amenable for any of the concurrent chemoradiation that is being offered, then you do a total laryngectomy. So again, patients who have poor performance status, patients who have a dysfunctional larynx, and these are patients who are better off treated with a total laryngectomy than being given concurrent chemoradiation. This is again patients who have T3 but advanced nodal disease. Again, concurrent chemoradiation is a treatment of choice. And if you have a T4 tumor, that is where the cartilage is involved and eroded, then the options are total laryngectomy, neck dissection, including the pretracheal and paratracheal lymph nodes, and varying degrees of thyroidectomy. Now, where do you do the thyroidectomy basically? In which patients do you do thyroidectomy? So, in some cases, the tumor can directly involve the lobe of the thyroid in the extralaryngeal disease. So, in those patients, you do a the ipsilateral or the side of the tumor, you do a hemithyroidectomy. And some authors have also described that if the patient has subglottic disease and he has pre and paratracheal nodes, it's better to do a total thyroidectomy. Now, total thyroidectomy is not difficult to do because these patients post surgery, if they receive RT, they will still develop some amount of thyroid insufficiency. But it's the parathyroid glands that we have to focus upon, and we have to take all precautions, especially when dissecting the paratracheal spaces, to preserve the parathyroid gland. So that is what is more important. Now you might end up with pharyngeal defects after doing a total laryngectomy. So you have different options for patch defects and different options for circumferential defects. So these are some of the options that we use to reconstruct the pharynx. Now, as I mentioned to you, salvage surgery should always be kept in mind, irrespective of the way you treat an early tumor or a T3 tumor. T4s are treated with total laryngectomy anyway. So, no form of organ preservation is successful if salvage surgery is not considered. Meaning, if the patient undertakes treatment for an early or a moderately advanced tumor, it should be in a center that is able to offer him salvage total laryngectomy, because salvage total laryngectomies are quite difficult to do, and they're prone with to have problems like poor wound healing and fistula formation. Now, salvage surgery, we have two types of salvage surgeries. One is the supracricoid partial laryngectomy or a total laryngectomy itself. But remember, these patients have to be followed up, and any signs of recurrence has to be treated with a salvage surgery. Now, I think everyone knows the total laryngectomy procedure and the technique. Otherwise, you can visit my YouTube channel. I've got the video of a supracricoid partial laryngectomy and a total laryngectomy there, so you can view that. In a supracricoid laryngectomy, partial laryngectomy is quite unique because these are meant for tumors which involve the vocal cord, but the arytenoid is spared. So this is the amount of cartilage you excise. Basically, you excise the entire thyroid cartilage. The reason being, this would have borne the brunt of radiation and probably received the maximum dose of radiation. And if you cut through this tissue, the patient is going to have chondronecrosis. So you remove the thyroid cartilage, the the entire thyroid cartilage posteriorly, but you preserve the cricoarytenoid articulation. And basically, the second picture shows you the hyoid bone. This is the cricoarytenoid joints, and this is the cricoid cartilage. And basically, you take sutures and you impact the cricoid cartilage to the hyoid bone and taking stitches through the epiglottis. So you can either have a supracricoid partial laryngectomy with the cricohyoepiglottopexy, or you can have it with just a cricohypexy. So there are two ways of reconstructing a supracricoid partial laryngectomy, and this is one of the options for salvage apart from a total laryngectomy. Now, after doing a total laryngectomy, patients can still have stomal recurrence. I think this is one of the important questions in the exam. What is the Sisson's stages or Sisson's classification of stomal recurrence? So, in a stage 1, the tumor is above the tracheostoma in the 9 is to 3 p.m. 9 to 3 position. The mediastinum is not involved. Esophagus is not involved. Here you have in stage 2, it's 9 to 3, but the mucosa of the esophagus must be involved for it to be stage 2. Stage 3 is the esophagus involved, and a tumor may extend to invade the upper mediastinum. And the stage 4 is when the mediastinum is involved, lateral extension under the clavicle, distal trachea, and carina. So usually stage 1 and stage 2, you can resect the tumors. They're surgically amenable, but stage 3, stage 4 are usually palliative treatment. Now, what are the non-oncological indications for total laryngectomy? So, a dysfunctional larynx is an indication for total laryngectomy because patients will be tube dependent, and if you do a total laryngectomy, they will be able to swallow without aspiration and speak with the aid of a tracheoesophageal prosthesis, or chondronecrosis because it's painful, it's usually post radiation, and these patients cannot swallow, cannot breathe. So, again, these are the two non-oncological indications for total laryngectomy. So, in conclusion, you have to be able to adequately stage the patient. Organ preservation is now the in thing for T1 to T3 carcinomas, and organ preservation includes both surgery as well as radiation. Transoral laser microsurgery, you should know the types of cordectomy, the indications and contraindications of transoral laser microsurgery. And whenever you're planning concurrent chemoradiation, always keep in mind that the patient may require salvage laryngectomy later on. So this is just a brief sort of overview of the CA larynx and the different subtypes and the treatment modalities that are possible. So I hope it was useful to all of you.
Thank you, sir. That was a really extensive and comprehensive topic on CA larynx. We'll take up two questions from the audience, and also I'm enabling unmute option. Any of the PGs who wish to interact, you can unmute and interact with sir. So the question from chat section is, what are the treatment options available for xerostomia after radiation?
So usually after radiation, I mean, currently everyone practices, especially for larynx, it will be a parotid sparing radiation. So most of these patients tend to uh, the salivation tends to improve at about 6 to 9 months. Otherwise, you have to use the mouthwashes, the salivary substitutes that are available, or there are some systemic agents like pilocarpine now which can be given, but it's not usually followed. So usually the treatment is use salivary substitutes, and when planning the treatment of the patient, it should be a parotid sparing uh, radiation. That's what is involved in these patients, the treatment of these patients. People have tried lots of things, salivary stimulators and all of that, but they all have severe side effects. So the only thing is now to physiologically substitute the saliva with an artificial salivary thing.
Next question by Dr. Ayush. Can you tell us what is involved in near total laryngectomy?
Okay, so near total laryngectomy is not a type of organ preservation surgery. It is basically a type of laryngectomy where you create a dynamic innervated shunt, muscular shunt, which is, it allows the air to go from the trachea into the esophagus and the patient can phonate, but the shunt doesn't, it's an innervated shunt with the cricoarytenoid. So it doesn't allow the saliva to escape from the oral cavity into the neck. So basically, you can try it for all patients, but the patient should have one functional cricoarytenoid unit to be able to do a near total laryngectomy.
Sir, Dr. Shruti, can you tell me treatment options for marginal zone cancer?
So if it's a T1, if it's a tumor which is limited to the aryepiglottic fold without involvement of the preepiglottic space or the medial wall of the piriform sinus, these patients can be treated with a transoral laser microsurgery. That is, patients who have T1 tumors. Patients who have T2 tumors have a higher incidence of occult nodal metastasis. So these patients are better off by treatment with radiation therapy, covering not only the supraglottic larynx but also bilateral neck. If the patient has a T3 marginal zone tumor, then the patient gets a chemoradiation in the form of cisplatin thrice weekly and 66 to 70 gray radiation. If it's a T4 marginal zone tumor where the cartilage is eroded, then these patients will get a total laryngectomy, partial pharyngectomy, thyroidectomy if required, and neck dissection. So T1 is amenable for laser. T2, if you want to do a supraglottic laryngectomy, you can do that. Otherwise, radiation is preferred. T3 chemoradiation, T4 total laryngectomy with partial pharyngectomy.
Yes, sir. Any more questions from the audience?
Someone asked what is 9 to 3. It's in the clock. From where 9 a.m. or 9 p.m. to 3 a.m. or 3 p.m. The upper quadrant. That is what 9 a.m. to 3 a.m. is. Or 9 to 3, that is what it means.
Sir, I think that's all for the from the chat section.
Yeah.
Thank you, sir. I'm sure.
Thank you everyone for staying back.
Thank you, sir. We'll end the webinar.
Yeah, thank you.